Good afternoon, everyone. Welcome to today's town hall. We'll just give a minute to try and get as many participants as possible logged in before we proceed. See about getting upwards of 150, so we'll just give it. I always like to wait just about 30 to 40 seconds to try and get as many signed in as we can. Have your audio and video ready to go. We have a packed agenda today, so lots to cover. We'll try and get right to it. My name's Aaron Levo. I'm the Vice President of Communications and Public Affairs. Pleased to be with you today on the Remembrance Day edition Town Hall, moderating our conversation. A bit of housekeeping off the top, just a reminder that we do have a Q&A at the end of our presentations, but that shouldn't stop you from posing questions using the Q&A function throughout the duration of the Town Hall. And the panelists that have joined us today can respond to those questions, and you'll see answers will accumulate in the Answered tab in the Q&A function. So I'd encourage you to go there and look and see if your question's been answered and maybe review what questions have been answered. If there's a topic on your mind, chances are it might be covered today, so you might want to wait for the panelists to finish before posing your question. That's okay too. At the end, we will pause and have a moment for a live Q&A, and should you wish, you can raise your hand and ask your question live. We'll call on you to do so. And then, as is in keeping with our tradition, we will close with celebrations today. So if there's something that's on your mind that you would like to shout out to a person, to a program, to a team, or recognize someone's work, give that some thought, and when that moment comes, you'll be ready to do so. Okay, so that's all I have to say. We'll get right to it. And I'll introduce our president and CEO, Rob McIsaac, who's going to kick things off. So Rob, over to you.
Yeah, thanks very much, Aaron. And good morning, everybody. Thanks for joining today. As we begin, I'd like to acknowledge that we are privileged to provide care on lands that Indigenous peoples have called home for thousands of years. As Aaron mentioned, we have another very full agenda and some really important topics to get through today. So I want to be brief in my remarks, but I do want to, of course, pause for a moment to honor Remembrance Day and Remembrance Week and all those who have served and sacrificed for our freedom and for peace. Today, of course, is Remembrance Day. It's marked at HHS through a number of different things, but most poignantly and visibly, the lowering of our flags to half-staff. Earlier this week, on November 8th, Indigenous Veterans Day, the very first Indigenous Veterans Day, was observed in honor of thousands of Indigenous individuals who have served, protected, and offered allyship throughout Canada's 200-year military history. An important aspect of reconciliation is acknowledging the role that Indigenous peoples have played in participating in helping to protect Canada as a free nation. With sincere gratitude for all of our veterans who have served our country, I'm proud to share with all of you a short video featuring HHS staff, patients, and volunteers reciting In Flanders Fields, written by Lieutenant Colonel John McCrae. So I'd ask if we could roll that video now, please.
In Flanders Fields, the poppies blow between the crosses, row on row.
That mark our place, and in the sky, the lark still bravely singing, fly.
Scarce heard amid the guns below. We are the dead, short days ago.
We lived, felt dawn, saw sunset glow. We loved and were loved, and now we lie in Flanders Fields.
Take up the quarrel with foe. To you from failing hands we throw.
The torch be yours to hold it high. If ye break faith with us who die,
we shall not sleep, though poppies grow in Flanders Fields.
Yeah, so what a nice way to involve many of our staff, volunteers, patients in this important observance today. So having done that, I'd like to turn it over to Sharon Pearson, who is our Executive Vice President of Clinical Operations and our Chief Operating Officer, to give us an update on the state of HHS's operations. Sharon, over to you.
Great, thank you, Rob, and good afternoon, everyone. And certainly concur, beautiful video and very poignant and very important today. For the operational update this week, I'll just start with the COVID numbers as we typically do. And again, just emphasizing those numbers much lower than what we had seen throughout wave 2 and perhaps the beginning, wave 3 and through the beginnings of wave 4. At our current numbers right now, we have 19 patients with 6 in the ICU, ward level or 10, and we have 3, actually that would be updated unfortunately to 4 patients on ECMO. So we continue to see the high acuity in this very small population of COVID that we have in the hospital right now. In terms of outbreak, we do have 1 active outbreak underway at the St. Peter's site on our palliative unit. If we go to the next slide, again, as every week, I talk about the occupancy pressures, which are not subsiding. If we look across our acute sites today, we see inordinate pressures reflected in the occupancy numbers. And perhaps just to make it very real, if we look at the JH today, it's 113%. West Lincoln sitting at 126%, which is staggering for a very small facility. 102% at McMaster and close to 110 at the general site. So all our acute sites are extremely pressured. There's a number of unfunded and surge beds open across all of our sites, well in excess of 70 beds, as we strive to balance those pressures across each of the organizations. We'll just remind everyone from a surgical activity perspective, we are still not back at our pre-COVID volumes, still sitting in the 80 to 85% range of our activity. Where we do see the increased volumes is through the ED and our unscheduled care. That is increasing the pressures within our sites. We also are experiencing some slowdown on the discharges, and part of that is reflected in the diminishing capacity we have in the community with respect to long-term care and the community beds available to us. That in part relates to some of the changes that were made through COVID to the physical footprints of our long-term care and retirement homes, limiting bed numbers, but it's also in part due to the health human resource pressures that are being felt across our sector, community, primary care, and acute altogether. If we go to the next slide, obviously one of the unfortunate sequelae of impact is to our ambulance partners, our EMS partners. So we have seen a rise in our offloads and the delays, which is extremely unfortunate. And some of you may have read some of the media coverage. It is a very complicated issue. It's a very large, broad system issue as well. And I would just tell folks that if we could easily remedy this, we would. But is it extremely complicated? It is driven in part by the volumes that we are seeing within the ED. And just again, to illustrate, if we look at the JH specifically, in the last 6 months, the volumes of ED within the JH are unprecedented. We have never seen such high volumes in the last 6 months if we look back over 10 years of time, so well in excess of pre-COVID activity. The volumes are being driven a little bit now by the seasonal illness that we see picking up, but also the impact that we see from COVID with some of the delayed care and deferred care. So that's reflected in higher numbers through the ED department as well. If we look across the province, we do have a higher volume of ED visits, a percentage that arrive by ambulance. The highest in the province is within the JHED. So there's some uniqueness to the organization as well. The Hamilton General is 5th in the province. So Hamilton community quite unique in the volumes that we have arriving to our EDs via ambulance. And I would just also want to highlight the physical capacity limitations within our department. The Juravinski ED was built to see approximately 85 patients per day. We're seeing 30% more than that right now. Some days way more than that. So built for 85 and some days seeing upwards of 150 patients. So we're just extremely limited from a physical plant perspective to be able to accommodate the volumes that we're seeing. So again, emphasizing it is a symptom of a much larger problem that we have across the sector. In terms of what we're doing about it, if we could flip to the next slide, there's lots of strategies that are in place and underway. We have had the benefit of having offload nurses in the ED for several years now. We have numerous pull strategies, one of which are the express units that exist across many units to help with that pull from ED. Numerous admit avoids strategies with partners like SE Health to expedite discharges from the emergency department. I mentioned the surge in unfunded bed capacity that we have put in place. Our CAT teams, as most are familiar with, the centralized access and transitions teams, again, to mobilize that flow through the organization. At the JH, a geriatric emergency medicine nurse was introduced a few years ago. And then, of course, what we've referred to previously is the census balancing that we do across our sites within HHS, but also with our partners like St. Joe's and Joseph Brant. So numerous activities underway in all efforts to alleviate these pressures on EMS and certainly the dangerous impact of having code zeros within our community. And there's ongoing forums with our EMS partners and St. Joe's in efforts to mitigate the issues that we're seeing. So my message today is we continue to have a very pressured organization and lots of strategies in place to try to moderate those pressures and certainly appreciate 100% what everyone's doing to assist in all those strategies. And with that, I'll hand it over to Aaron.
Yeah, thanks very much, Sharon. Great update today. Next up on our agenda, I'd like to invite Dr. Smita Halder. Smita is the co-chair. Amongst other titles, she is currently the co-chair of the President's EDI Advisory Council and here to give us an update on the work that group has been doing. Dr. Halder, over to you.
Thanks very much, Aaron. So thank you. I'm pleased to provide a brief update today on the work of the President's Equity, Diversity and Advisory Council. So I, along with Bruce Squires and Dr. Sanjay Sharma, co-chair this council, and we're fortunate to work with a really dedicated and committed group of HHS staff, physicians, patient advisors, and they've all volunteered to join the council. The key initiative in Hamilton Health Sciences' annual strategic plan is to design and implement a framework to elevate our organization's performance in the areas of equity, diversity, and inclusion. And to help drive this strategic initiative forward, the President's Advisory Council on EDI was convened in late 2020. The council is focused on developing recommendations to support a more equitable, diverse and inclusive organization. But ultimately, we're working to ensure that all of our staff, physicians, patients and learners, as well as members of the public, are made to feel welcomed, respected and supported by HHS. And I'd really like to thank our colleagues who've been working together over the last few months to shape this work. Despite the fact that our initial work has been undertaken while our hospital responded to the pandemic and supported the recovery plans, the council's made some significant progress to date. And I'm here today to provide a brief update where we're at and where we're headed next. Next slide, please. So, the council's commitment and dedication has moved us through a time of shared learning and development to establishing 4 key areas of focus for our work groups, within which we plan to build a series of recommendations. So we've got an established council membership and terms of reference. We've engaged in learning and set the guiding principles. We've selected a framework to identify 4 key areas of focus and created 4 working groups to establish the objectives and develop those recommendations. The 4 key areas are organizational commitment and integration, professional practice, education and research, compositional diversity and community, and systems interaction and culture. And the 4 working groups continue to make very good progress on articulating those objectives, and we're beginning to compile some recommendations. A vital next step in this process is broader engagement of our workforce and partners. We're going to do this through interviews, focus groups and other means. And it's being done to provide a more complete understanding of what the organisation's current state is, any gaps that are present and any opportunities that can help inform the council's work to prioritise the recommendations for the next steps. A review of the HHS policies and processes are also being undertaken to identify those gaps. And we're pleased to have an external partner, Ernst & Young, who's working with the council to provide additional expertise and support and help us deliver on this mandate. So in the coming few weeks, we're going to be sharing more details about the work ahead, including the opportunities for you all to be involved. So please stay tuned to all the usual staff and physician information outlets, the Hub, the Daily Dispatch, and the town halls. And now I'm just going to turn over things to Tiffany Roblin. She's the Director of Employee Labour Relations and Human Rights, for some information about a specific observance that's happening later this month, the Trans Day of Remembrance. Thank you.
Thanks very much, Snita. I'm here today to bring awareness to Trans Day of Remembrance, taking place in just over a week from now on November 20th. Trans Day of Remembrance is an important opportunity to memorialize those who have experienced violence and death as a result of anti-trans violence. It's also an opportunity to continue to draw attention to the violence, discrimination, and exclusion trans folks experience every day. Trans advocate Gwendolyn Ann Smith began Trans Day of Remembrance in 1999 to commemorate the death of Rita Hester, a Black trans woman who was murdered in 1998. While trans folks regularly experience violence, discrimination, and exclusion, it is important to remember that this is especially the case for trans folks who are Black, Indigenous, racialized, disabled. Rita Hester's murder has never been solved, and she was regularly misnamed and misgendered by police and reporters at the time of her murder. Next slide, please. While healthcare institutions should be safe and inclusive spaces for all, they often are not for folks who are trans, two-spirit, and gender non-binary. The Trans Pulse Project began in Ontario as a community-based research project that investigated the impact of social exclusion and discrimination on the health of trans folks in Ontario. It has since evolved into the Trans Pulse Canada study. In 2015, Trans Pulse Ontario reported that 10% of trans people who accessed an emergency room presenting if they felt in the ED, my apologies, felt gender, were refused care and had their care terminated prematurely because they were trans. 25% of trans people reported being belittled or ridiculed by an emergency care provider for being trans, and 21% reported avoiding going to the ED entirely when they needed it due to fears of how they would be treated because they are trans. While this data focuses on experiences in emergency departments, we should not assume those are the only spaces in which trans folks do not experience the safe and inclusive space that they deserve, as we all deserve as humans. Trans Pulse Canada launched a national survey in 2019, which was expanded in 2020 to analyze the impacts of the COVID-19 pandemic. Results of the national survey are forthcoming. At HHS, we are striving to ensure our spaces are safe and inclusive for everyone, and we have implemented policies and processes to support this goal. In 2019, we implemented our gender identity and gender expression policy. Folks who tuned into the town hall back in June may recall Nate Sarosky in talking about Pride, encouraging folks to check out our policy and the resources included within it. If you did not look at the policy at that time, or even if you did, we encourage you to check it out again and understand your responsibilities as a member of the HHS community to all trans, two-spirit, and gender non-binary folks. In 2019, we also launched our Trans Inclusive Service and Care Initiative. Several components of this initiative have rolled out to date, including over 70 all-gender washrooms across all of our sites. These washrooms create space for folks to feel safe, knowing that they do not have to risk harassing encounters with others while using the washroom. Again, please do take a look at our gender identity and gender expression policy to learn where all of those all-gender washrooms are located across HHS sites. We've also installed over 300 trans-affirming washroom signs, as you'll see here on the slide, on the exterior of gender binary, so those male and female washrooms at a number of our sites. Installation at other sites will continue as the pandemic subsides. These trans-affirming washroom signs remind everyone in HHS spaces that trans, two-spirit, and non-binary folks have the right to use the washroom that best fits their gender identity and gender expression, free from discrimination or harassment. The Human Rights and Inclusion team also offers Two-Spirit and LGBTQIA+ positive space training through the Center for People Development. This is a free training opportunity for all members of the HHS community. As everyone likely knows, we are moving towards implementing EPIC in June 2022 as we complete Project Odyssey. This will be a huge step forward in building safer and inclusive spaces for everyone, but especially again for our trans, Two-Spirit, and gender non-binary folks within our workspaces and accessing our sites. Our current Meditech system requires that staff input a patient's name from their health card only. And for many, this name is not the name they use themselves. There is no easy way to document the name the patient uses for themselves or the patient's pronouns. With EPIC, we will be able to input a patient's name on their health card for billing purposes while prioritizing the name that they use themselves and their pronouns to support staff and physicians to not accidentally misname or misgender patients. Stay tuned to learn more about this as education on how the EPIC system is rolled out. And as we often do, we always encourage folks to check out the Human Rights and Inclusion Hub page, which is full of resources on this topic amongst many, many others. This year, to honor and commemorate Trans Day of Remembrance, we are revising our email signature brand guidelines to support staff and physicians in sharing their pronouns in their email signature. Again, if you feel safe to do so. We've provided an example here for you. As you can see, folks are welcome to offer any pronouns that feel right to them. That might be their gender binary pronouns like she, her, he, him. It might be gender neutral pronouns like them or they or ze and zir. And it might be a combination of both gender binary and gender neutral pronouns like she and her and they and them. This is just an invitation, and again, no one is required or expected to add their pronouns to their email signature, as folks may not feel safe or comfortable to do so. HHS's updated email signature brand guidelines will be made available to all via Hub Story and Daily Dispatch on Friday, November 19th. So please stay tuned for that, but of course, feel free to add your pronouns to your signature prior to the 19th, again, if that feels right for you. For those Zoom profiles, we're also welcoming and inviting folks to add your pronouns to your Zoom file. This is, again, voluntary and not required. I appreciate this image may not be accessible for all viewing our town hall today, so I'll take a moment to briefly explain for folks the steps to do this. If you log into your Zoom account, you can either go to the My Profile section if you're using the Zoom application, or just the Profile section on your browser version. Once in your profile, select Edit. Towards the right-hand side of the screen, next to your name and photo, you'll see, again, that Edit button for you. And within that, you'll find a new field to add in your pronouns. You will also be prompted to consider how you would like to share your pronouns. Your options are always, ask me every time I join a meeting, or do not share my pronouns. So we encourage folks to consider adding your pronouns again to your Zoom profile, but again, only if this feels safe and comfortable for you. Sharing our pronouns is so important for many reasons. To start, we all have pronouns, but often folks who use those gender binary pronouns, so she or her, or he and him, only notice or think that communicating pronouns is something that trans, Two-Spirit, and gender non-binary folks do. We all have pronouns, and we actually share them without realizing, simply in the way that we speak about ourselves on a day-to-day basis. When you share your pronouns, whether it's in your email signature, in your Zoom name, when you introduce yourself to folks with your pronouns, you're both normalizing the act of all humans sharing their pronouns, regardless of their gender identity, and you communicate to those around you that you understand the importance of using pronouns and getting pronouns right for folks. This may make your colleagues or patients feel safer to communicate their pronouns to you as well. If you'd like to go even further, we strongly encourage you to consider offering your pronouns when you introduce yourself. For example, my name is Tiffany Roblin and my pronouns are she and her. When you offer your pronouns, when you introduce yourself, you do the same thing as when you communicate those pronouns in your email signature. You're creating a safer space for folks who are trans, non-binary, or Two-Spirit to know that you understand pronouns. They may then feel safe to share their pronouns with you as well. As always, if you'd like to learn more, there are so many resources to support you. McMaster's Faculty of Health Sciences is hosting Providing 2S LGBTQIA+ Healthcare, a panel discussion on November 18th at 5 p.m. To register, simply Google McMaster FHS Providing Two-Spirit LGBTQIA+ Care, and you will find the link to register. Again, our gender identity and gender expression policy is available for you on the policy library. And as I've just introduced, our updated email signature brand guidelines. In addition, Human Rights and Inclusion has created an infographic to support you in learning more about why communicating pronouns is important, what your pronouns might be, and how to answer questions if folks are asking why your pronouns are in your email signature. We also encourage you to enroll, if you haven't already, in our Two-Spirit and LGBTQIA+ positive space training through the Center for People Development. External to HHS, you can always learn more from the Hamilton Trans Health Coalition, the 519, Rainbow Health Ontario, and so many more resources. With that, I will hand things back to you, Aaron.
Thanks very much, Tiffany. Thanks for that update. Very informative, as always. Next up on our agenda, I know infection prevention and control professionals nationwide have been thrust into the limelight during the pandemic, but Dr. Dominic Mertz remains my favorite IPAC professional. He's here today to give us another update about the epidemiology of what's happening across Canada and locally. Dominic, where are we at?
Yeah, thanks, Aaron. You're clearly biased, but thank you anyways. Yeah, where are we at? I think people are well aware that that's from October 26, what you see here, when most provinces were heading downwards in terms of their case numbers, which is reflected by the green arrows that you can see here. And mostly Northwest Territories was challenged, as well as the First Nations reserves, which you see at the very bottom there. Things have changed, as you're well aware. That's on the next slide, the current status by November 10. And you can see that those provinces that were very high, like Saskatchewan, like Alberta, have come down significantly, but now seem to plateau, or Saskatchewan still decreasing, but certainly not to the same extent. While we now see those provinces east to Saskatchewan starting to go up, Manitoba, ourselves in Ontario, but also Quebec. We see New Brunswick and the highest RT currently in Nova Scotia, with of all those provinces, Ontario still having the lowest numbers, but certainly a dynamic that's going upwards at this point of time. Next slide. The PHAC models, the latest one from last week, and how we compare, we are pretty much following the black line at this point. But with now everything like east from Saskatchewan heading upwards, I expect us to get closer to the blue line there over the next week or two. While cases in the west are coming down or have come down, now we will continue to see probably the increase more like in the east. Next slide. This is our provincial case numbers, as you can see, and I added the black line where I sort of expect us to finish the week higher than last week, given our current trajectory, that's for sure. We are comparable to where we have been sitting end of September in 2020 in terms of case numbers right now. Next slide. In terms of hospital admissions, similar to mid of October, quite stable over the last 6 weeks, I would say. Before that, we had the decline at the provincial level. Things so far stable. Next slide. How do we compare to the latest Ontario models? You can see first following the green line, and then we started to see that increase. Now we are where the yellow line is, and I would expect us in a week or two to probably cross that red line as well. So a very different trajectory than what had been predicted October 22nd. However, next slide, when you go back to the model before that, which suggested an increase in case numbers towards the end of November, that's what's actually happening now. We just sort of are starting lower than have been predicted back then. It just shows you how extremely difficult it is to make any predictions at this point of time. on how the trajectory of the pandemic will look like for us and elsewhere at this very point of time. Next slide. In terms of ICU occupancy, looking okay, lower than expected, pretty much sitting at 130 now for a couple of weeks. There's been a question in the chat about half of hospital admissions being in vaccinated, of ICU admission. Definitely not. You're looking at 10% fully vaxxed versus 90% not fully vaxxed in the ICUs in Ontario at this point. Next slide. Hamilton, very stable in contrast to many other public health units. We don't see that increase, or not yet. But on the other hand, we had a very significant wave 4 or wave 4A. We are currently pretty much where we've been October 2020 in terms of case numbers. Next slide. These are our unlinked cases for 100,000 per week, which, as you know, we use for our policy decisions. We stayed in high epi until basically this week from a policy perspective. But now we've been stable, we've been declining for more than a month, so we felt it's the right step to take, knowing that we may head towards a non-low epi, but based on the local modeling that I will show you, we don't necessarily expect to get back in high epi as long as the models hold true. So that's why we made this step. Next slide. The main change with being considered back in low epi is really about those people with symptoms that you can easily explain by something else. So your patient with appendicitis and fever, your fever is explained by the appendicitis, does not need a test anymore, which makes our flow in the ED easier because we wouldn't consider those people suspect at this point, while adding very, very little additional risk given the low likelihood that someone who happens to have a fever and, let's say, an appendicitis, to have the fever actually because of COVID and not because of the appendicitis. So that's the rationale for this change in policy, which we made several times through the pandemic at this point. Next slide. Hospital admissions here, Sharon already mentioned, we are in quite good shape. And if we deducted the outbreak-related cases in St. Peter's, then we are actually where we haven't been since summer last year. Right now, with those cases considered as well, we are where we have been mid-November 2020. So pretty much where we've been a year ago. Next slide. That's the modeling for the city of Hamilton. Not up to date, that's from October the 12th. There's no publicly available model since, but I can tell you it hasn't changed a lot. It looks a little bit more optimistic than what you have here. But even with this, with a mid-December peak in the 100 cases per day, that should be manageable from a hospital capacity perspective. It will translate, and that's on the next slide, to most likely scenario, 2 admissions per day, worst case scenario, 4 admissions today. But again, that's modeled, but we've been at as much as 10 admissions per day at the peak of the second wave, of the third wave, sorry, in April. Next slide. I was asked last week about which countries to watch, and I could probably talk half an hour about what's happening in Europe and how much or how little we can conclude. And I just give you a couple of examples here. Austria, highest case numbers currently, they overtook England. So Austria is the blue line that you can see here. They have the highest hospital admission rates, again, overtook Great Britain. They have by far the highest testing volumes, including a lot of rapid testing at home. They have respirators, so N95 equivalent mandates in the community. And on paper, most restrictive of all the countries that I listed here, other than Canada, we are still more restrictive in terms of our public health measures. And nevertheless, they see that significant jump. So it's very difficult to say what's happening there and why it's happening, other than a significant lower vaccine coverage than we have in Canada. So I guess that's the good news. Next slide. Another example, Great Britain, I showed data repeatedly that had its Freedom Day beginning of July. Cases continued to increase after Freedom Day, then came down, plateaued, up and down, now going down again, while the rest of Europe or many countries in Europe are going up. Again, very hard to explain why we see this, this dynamic in the UK, probably a combination of increasing vaccine immunity plus adding natural immunity to the mix, which probably keeps things more or less in check. Hospital admissions have been climbing to an extent that it became more and more challenging now over the last few days. There's a decline as well. Again, it needs to be seen how things will evolve from here in the UK. Next slide. And then an example, Denmark, which you read quite a bit in the media because they dropped their pandemic measures early September. Norway did so a few weeks later. They have also high testing volumes, not as high as Austria, but much higher than what we would be doing. But they now also see an increase in hospital admissions, and they are considering to re-implement some measures, in particular indoor masking and probably some level of certification. I forgot to tell you which color, so that would be the yellow curve there. And I added Canada as the green line just to give you some perception. So you would see that Denmark is roughly 4 times higher than us at this point of time, and Austria much, much higher, and the UK as well. Next slide. Portugal, to give you a good example of a country that's going well, and you hardly see that here. It's the blue line. That's pretty much where our green line for Canada is. They had much higher case numbers over summer. They reduced their measures step by step, similar to what we've done over summer, but they continue to see a decline in case numbers. They have very high vaccination rates, and by very high, I mean 87% of the population, though. So that's more than 10% higher than what we have in Canada. Hospital admission and case numbers are low, similar to where we are currently at in Ontario. So certainly for me, another country to watch, to see a larger country, how they will be doing with releasing more and more measures, and so far doing well, while in contrast, others that did the same are not faring well. Next slide. So in summary, Ontario is currently following trends of several European countries with case numbers climbing. As I mentioned, there's exceptions for countries that still remain at very low numbers in Europe as well. And it's very difficult to fully explain those different trajectories that we observe in Europe. There's countries with cautious policies, not necessarily doing better or far worse, like Austria. Then you have those that declared the pandemic over, that now considered reinstalling some of those interventions, like Denmark. Others like the UK that just stay relatively stable, but at a very high level. And the southern European countries in the West in particular tend to be doing better. So Italy, Portugal, Spain. Is that because of the climate? People still more outside than in those other countries? Is it the higher vaccination rates, or is it the policy or the adherence to the policy that keeps things in check? All of this being said, the same summary in 4 weeks may look very different because maybe things change very significantly in those countries as well. So just the bottom line is be very careful in just picking one country and draw any further conclusions from that. It's very difficult these days to explain the trajectory in a specific community as to why A or B happens. Next slide. Let's go back to Ontario vaccination rates, comparing Ontario at large to Hamilton. We are still lagging behind in terms of first doses by 3%. Next slide. Second doses, 3.1%. And the next slide, now we have the third doses added. I would say for the least important dose, we are doing better than the average of the province, but we should really catch up with the first and second doses in mind. Next slide. Talking about those third doses or booster doses, what are the criteria? So first of all, Moderna Pfizer can be used interchangeably. Populations qualifying are residents in long-term care, retirement homes, and other congregate care settings, and community dwelling adults 70 and older, the First Nations, Inuit, and Métis, and those who have received AstraZeneca or Covishield, which are the same as first and second dose. And of course, most important for this population here, the healthcare workers. A 3-dose regimen is recommended for immunocompromised individuals, and you can look up the exact definition of any age where the second dose is given at least 2 months after, the third dose is given at least 2 months after the second dose, while the booster dose is to be administered 6+ months after the second dose. Next slide. Now, what data is informing those kind of recommendations? I show you the Ontario specific data here. So on the very left-hand side, you see the risk of symptomatic infection and waning of immunity against symptomatic infection. And you would see that in particular, if you receive your vaccine within an 8 weeks interval, it's more likely that you have some level of waning than if you had a longer interval. In the middle, you see severe outcomes, and you can see it doesn't really matter in terms of the interval between first and second dose. There's very limited waning, if any, when you look at severe outcomes. They're still holding up very well. In the age group of 70+, you would see that there's some waning maybe happening, a few percentage for severe outcome, which is the orange line. For symptomatic infection, after week 23, after the second dose, you see a quite significant drop in vaccine effectiveness in preventing mild disease. And these are the kind of data that inform your recommendation for third doses. So last slide, in terms of recommendations for healthcare workers in particular, if you are a healthcare worker and more than 6 months out from a second dose, you are eligible for a third dose or for a booster dose. You would benefit most of it if you are older age. And obviously there's nothing magic about 70. If you're 65+ or 65+, you probably benefit more than a 20 or 30+ old individual. If you're immunocompromised, you're more likely to benefit. And if you had a short interval between the first and second dose, but that's mostly those folks who would have had their doses very early in January and February. And the third dose is a choice and not a mandate at this point. Just to be clear about that, you can choose whether you want to get your third dose or not. Okay, thank you very much, and handing over to you, Aaron.
Thank you very much, Dominic. Great stuff, very informative today. Next up on our agenda, we'll invite my favorite Vice President of Health Information Technology Services, Michelle Leaflor, to give us an update on where we're at with our Project Odyssey work. So Michelle, over to you.
Well, thank you for that kind introduction, Aaron. Happy to be here today to provide a brief update on some key activities going on with Project Odyssey. You're quite familiar with this project roadmap. We've been sharing it with everyone to show you where we are in our journey. Currently, we continue in phase 3, where the teams are primarily focused on testing the system, ensuring that it's going to do what it needs to do when we go live, based on all of the input of hundreds and hundreds of stakeholders across our organization who have been part of the build process. Once testing is done, we'll move into other critical readiness activities, technical dress rehearsals, go live readiness assessments, and a number of change management and engagement activities that will be coming across the organization shortly. Next slide, please. We are 204 days away from go live. We're very close to completing the journey to get to our starting line, to be able to use Epic to enable care across our broad organization. Next slide, please. A couple of key updates we wanted to share with you today. Training is one of the most critical success factors for go live. Everyone, all 13,000 plus, who will be an end user of Epic must be trained before June 4th. Our leaders will soon be instructed on how to register their staff for the classroom training that they'll be required to take. Before your in-class training, the first step for all staff and physicians will be a series of short e-learnings, videos, and quizzes, and you'll be required to complete those before you attend your in-class training. These will provide a foundational understanding to enable your better processing in class. You'll soon be notified by email when you can begin your e-learning, and that is going to start as we assign you to your programs. You'll have up until April to complete those e-learnings. So although you may get notified within the next 4 to 6 weeks, you'll have up until your first class to complete those. Much more information will be coming around training, and that'll be shared on the Hub and via your leaders in the coming weeks. Also exciting is we continue to roll out new devices. Over 9,000 new devices are currently being delivered to all of our clinical support and administrative areas across HHS. This is all part of becoming a fully digital hospital. Newer hardware, newer networks, and better technology for you all to use in providing care to our patients, such as viewing patient information more quickly. Many of the devices that we're installing now won't be used until go live, but because of the sheer volume and size of our organization, we need to deploy early as we prepare for items like the after Christmas stress rehearsals that require further testing. We do have one ask of you. We have identified the new equipment with a sticker, and we would ask if at all possible to avoid moving them, so as we come back after Christmas to do our other exercises, we'll be able to easily locate them. Next slide, please. The training pathway for our end users is consistent across our groups. E-learning, followed by classroom, followed by class exercises and other engagement activities that you'll hear more about in the upcoming months, brown bag lunches and other activities. A small test or assessment to make sure that people are comfortable in how they've absorbed their training. All things that will be enabling you all for success as we move to go live. Next slide, please. So I just want to remind everyone, there's a wealth of information that our change management and comms and OD teams have been putting out on the Hub, and please go to the Hub for more information on those latest updates. As well, we have a team that is readily available to answer questions, so please send those to us at odyssey@hhsc.ca. Again, I'd like to thank you for your support and continued engagement for Project Odyssey, and look forward to the next 204 days ahead. Thank you, Erin. I'm going to hand it back to you.
Thanks very much, Michelle, for that update. Next up on our agenda, our Director of Child and Youth Acute Health, Lisa Webster, is with us to give us an update, I believe, about the United Way campaign. Lisa, how are things going, and what can you tell us about the campaign this year?
Erin, thank you so much. I'm happy to be here to talk about our United Way campaign efforts this year. I first want to just give a shout out to our VP sponsor, Kelly Campbell, and my co-chair, Kelly O'Halloran, for their support and all their hard work in launching this campaign, as well as the working group. So our HHS United Way campaign is now really nearing its halfway point, and our goal is raising $90,000 for our organization. And by supporting the HHS United Way campaign, you're helping local community recover and rebuild from the pandemic. As we know, it took quite a toll on our community, and we are happy to be part of this campaign to help in the recovery process. Amongst the most powerful ways to provide your support, as we know through past campaigns, is the one-time gift or payroll donation. So I'd just like to take this opportunity to really encourage, if you have not done so already, to please consider a one-time gift or payroll deduction donation. As we know in the organization, it is very impactful in the money that we've raised through this method. Please also consider taking part in our hospital virtual fundraisers. We've got a number of fundraisers on the HHS Hub, and I encourage all of you to go on the Hub and click on the various icons that actually outline the activities. And there are site-based activities this year. And that's really encouraging, considering we get to be with one another. And so that's lots of fun. And I know that the sites are very engaged in that, as well as corporate events and corporate draws. All the information is on the Hub. And so I ask everybody to get involved, get engaged. Let's help our community. Let's reach our goal of $90,000. And a sincere thanks to everyone for all their hard work in the campaign. Thanks, Erin.
Okay, thank you, Lisa. Appreciate that update. Now we do have time for usual Q&A. I know our panelists have been very, very busy responding to questions in the Q&A forum. So you can review what's been answered by clicking on the Answered tab, and you'll see several answers there. I want to try my best to pick up on some of the themes that were arising in the questions. Maybe it's important to pose those to our panelists. Dr. Mertz, I know you've been very busy typing. In particular, there's a couple of repeat questions there around, where we go to get the best information about what's happening in the pandemic in Ontario. As a as a health professional and someone accountable for planning IPAC at our hospital, where do you turn to for information? Where would you suggest people look?
Yeah, I mean, there's multiple options. Some are open to the public and others are not. I'm usually using some of the public health and COVAX Ontario websites that are not accessible to everyone. So that's where I pull some of those figures that I'm presenting. Public Health Ontario has a great website. Ontario, of course, has a great website with a lot of information. And for the daily updates, you can follow Christine Elliott on Twitter, and you will get your case numbers, how many vaccinated, unvaccinated, how many in hospital, and so on. There's been a comment by an anonymous person who was like, well, why are you getting information from Twitter? Well, because it's your official information that we would get from the ministry, right? Which will inform the public health website as well. You also need to be careful. Sometimes you get number of admissions, for example. Others would report total number of people hospitalized at the given time point. And another difference that you may see sometimes is that in those daily updates, you will get fully vaccinated versus not fully vaccinated or unknown status, while you get slightly different data on some of the websites. So again, those numbers superficially don't necessarily line up. And I think another piece, and I hear that more, yeah, the vaccines don't work. No, they work, and I can show you the same data every single week. But I think we get to a point where it's getting too repetitive. But fact is, yeah, even if we see 50% fully vaxxed versus 50% not fully vaxxed, when you have a population where those at risk are 90% fully vaxxed, you sort of expect that those breakthrough infections will eventually be probably the majority of people once you have a very small pocket of unvaccinated people left. So it's very important to consider your denominator when you think about, oh, 50% of the cases today are unvaxxed. Yes, but 85% of those eligible are vaccinated at this point.
Yeah, good perspectives on that. And while I have you, just I don't think we touched on it today, but any advice around? I know it's come in through our question line quite often around coordinating the flu shot with vaccination for COVID-19. I know you've touched on it in the past, but maybe you could just remind us what should we be thinking?
Yeah, so the National Advisory Committee was quite clear that you don't need to make any special considerations. So you can take the two shots, let's say the booster shot for your COVID and your annual flu vaccine on the same day, or you can have any random interval between the two. It's entirely up to you. There's no limitations in any way. There's no risk in terms of reduced effectiveness to the best we know, or in terms of safety. So you can do whatever fits your schedule best.
And perhaps you, or maybe Bruce Squires, I think is on the phone, maybe he knows as well. What's the current state of planning for vaccination for kids? Is there any movement right now, or any plans we need to be aware of?
Thanks very much, Aaron. So certainly we know that both Health Canada and the National Advisory Committee on Immunization are in the process of reviewing the data submitted by Pfizer with respect to the 5 to 11-year-old cohort. We also know by public messaging from the Prime Minister that Canada has indicated it has secured sufficient supply to vaccinate all Canadian children between the ages of 5 and 11. So now we're just waiting for the approval to come first from probably Health Canada first, and then NACI. And indications would be that can be expected sometime in the next several weeks to a month. Certainly I'll just close by saying McMaster Children's HHS continues to be part of the Hamilton Health Partners that are actively planning for that portion of the vaccination rollout as soon as the approvals come.
Wonderful. Thanks for that update, Bruce. Well, I am conscious of time. I know we have been dutifully, our panelists have answered about 25 questions currently in the Q&A. They're going to keep at it. So if you do have a question, please pose it. You can also continue to ask questions at hhsnews@hhsc.ca. Want to make sure that our content is informed by the most pertinent topics to our workforce. So please send a question there. It's very helpful to receive. And now we have a moment for celebrations. So we'll use our chat forum. We'll open that up and we'll let people type in their celebrations. As is our usual custom, if you would like us to read it out, put it in there, we'll read it out. If you'd like to give your celebration live, you can raise your hand and we'll call on you to do so. Always nice to hear. So that goes for our panelists as well as our participants. I would love to hear some great celebrations and shout outs today. I know that in particular, I'd want to acknowledge in the Q&A some folks earlier on pointing out their thanks and gratitude to Dr. Mertz and certainly all of our panelists for grinding away, answering questions as best they can. I know it's a lot of information coming in and they do try very, very hard to provide thorough answers to each question. So thank you so much for doing that. I also see from Kelly Campbell here, a shout out to Lisa Webster for championing our United Way campaign this year. As chair for the second year, we really appreciate your efforts. Thanks very much, Lisa, for that. And thanks, Kelly, for that shout out. Also see here from Leslie Gillies, also to Lisa, thanks, great presentation, another acknowledgement. And from Dr. Natasha Johnson, who's with us today, shout out to Employee Health at the Mumsy site for delivering the flu shots that are being handed out so efficiently. Great recognition. Thanks for that, Dr. Johnson. And then what else do we have here? Oh no, I've lost my screen. Hold on. Let's go back. Sometimes there's just too much to manage on this screen. Give me one moment. There we go. Something from Bruce Squires. Congratulations to Susan Nall, Manager of Child Development and Rehab Services, as she leaves the Master Children's Hospital and HHS this week after 20 years with us. Sue's taking on a leadership role at the Ontario Children's Treatment Network. Thank you, Sue. Thanks for your service to HHS and best wishes for sure in your new role. Thanks for highlighting that, Bruce. So once again, if someone has a shout out that they would like to give live, just raise your hand. That could be a panelist, could be a participant. Here from Krista Binnington, happy Nurse Practitioner Week to all our incredible NPs. We have so many incredible NPs and our patients, families, and teams are lucky to have you. Without a doubt, Krista, thanks for putting that forward. Happy Nurse Practitioner Week to all of our NPs. From Kelly Campbell, congrats to Annette Lasavita, celebrating 20 years at Hamilton Health Sciences. Congratulations, Annette. Good for you. From Leslie Gauthier, celebrating Perioperative Nursing Week. A big thank you to all of our perioperative team for all of the work you're doing. Good stuff. Perioperative Nursing Week. Congratulations to all our periop nurses. Chat function is open for celebrations. Yes, let's celebrate that. Let's celebrate that we're celebrating. Good stuff. From Janine, happy MRT week to all of our amazing, we'll lost that one here, technologists in diagnostic services. They're coming in fast and furious now. You're challenging me. Thank you. From Aaliyah, to all HHS staff, physicians, and volunteers who believe and trust in the science and keep doing everything to keep us all safe. Thanks, Aaliyah, for that shout out to all. From Alana Barish, thank you for the leadership team for working diligently to provide a safe and inclusive environment. Thank you for all the work you have done on the vaccine front, and thank you to all the clinical staff for the work you are doing to serve the community. Great one. Thanks, Alana. From Kelly Campbell, a welcome to George Pankew as the new Director of Capital. All right. Welcome aboard, George. Salutations from Patrice Cloutier to current and former reservists who work at HHS. Great, and you might have seen Patrice's shout out earlier during our Remembrance Day celebration to all our reservists. We're acknowledging that service comes in many forms. From Wendy Seidlitz, happy retirement to Judy Delario next week. From our Master Children's Hospital patient safety specialist and former NICU RN and neonatal transport nurse. Happy retirement, Judy, next week. From Michelle Leaflor, congratulations to Kathy Massey at HITS, who will retire at month's end after 40 years at HHS. 40 years, Kathy, congratulations. Thanks for all you've done for Hamilton Health Sciences. One here from Liz Ferris to the JHED team, who have a veteran in the department today. They helped dress him in his uniform and observed a moment of silence together at 11. That's incredible. What a great story. That would make a great story for our internal newswire. So for sure, thanks Liz for pointing that out. From Kelly Turner, bravo to the ED team. Wonderful person-centered care. Thanks Kelly, and bravo to all our ED teams for working so hard right now. It's a very busy place. Happy retirement to Heather Kerr, 40 years on the 4th floor at the Mumsy site. Today is her last day. So lucky to have you for another 40-year service retirement. Wonderful to see. That's from Kelly Valancourt. So happy retirement, Heather. Okay, well, that was a workout. And we thank you very much to everyone for all the celebrations. Maybe Rob, if I could press you into service for some final words. Thanks very much.
Yeah, thanks very much, Aaron. Good job today. I guess I'll just say thanks, first of all, to all our presenters today, who I thought did a really excellent job. Maybe just more broadly, as Sharon noted, the hospital is under such great pressure. So I know I can speak on behalf of the leadership team and thanking everybody for all of the things that they're doing. And from me to the leadership team, thank you for all that you're doing to help the organization try to cope with these very challenging times. It is a very, after almost 20 months of pandemic, I know pressures are very high on everybody in so many different respects. And, the management team, the executive team absolutely takes no pleasure in doing some of the more difficult things we're doing around vaccine mandates. But we are doing it because we believe it is the right thing to do. For those of you who spoke up today in support of what we're doing, thank you for that feedback. It's much appreciated. But I would say to everybody, we do not relish in the prospect of having to move to discipline in respect of people who have not been vaccinated. I would just ask people, please get vaccinated. That is our policy, and we're intending on carrying it forward. So thanks very much, everybody, for attending today, and we'll see you all next time.